Hello, I'm Mary Beth Marsden, and welcome to GBMC's Oncology Ask the Expert. And today's expert and today's guest has had a long and distinguished career and is still involved in groundbreaking research. So please welcome today Dr. Paul Celano, Herman and Walter Samuelson's medical director of the Sandra and Malcolm Berman Cancer Institute. A mouthful, but you do a lot, so it says a lot. Thank you for being with us.
Well, thank you for having me today.
There are a lot of people who are joining us. We've had more than 100 people respond to today's conversation, and they're joining us right now. And a lot of those people are very aware of your history and what you do on a day-to-day basis, but a lot probably aren't. So I think let's just start by just talking about your background, your interest in cancer, and how long you've been doing the work you've been doing.
Well, my interest in cancer and in science goes back since I was a child, actually. My aunt unfortunately died of ovarian cancer when I was young. It had a big impact on me. And so it really inspired me to understand better about illnesses and cancer in particular. No, I'm the second member of my family to go to college. My oldest brother went to the Naval Academy. So from high school, I was born in Philadelphia. I went to college at the University of Pennsylvania. Fortunate to have a lot of good experiences there in science, and then went to Mount Sinai School of Medicine in New York City. Had also excellent training and experiences of some of the leaders of clinical trials, which has really been a large part of my career. Then down to Jefferson and back to Philadelphia for 3 years for my medical residency, and then to Johns Hopkins, which really is what got me to Baltimore, to be honest with you. I hadn't been much to Baltimore until I came to Johns Hopkins for my medical oncology training. And of course, this has was a wonderful experience and training. I spent another 6 or 7 years at Johns Hopkins doing medical research. But my real interest has always been in patient care and what happens to patients. And that's what brought me out to GBMC because of their long history of excellence in patient care and the developing cancer program. So over the last 20-odd years, we have really developed this program of GBMC into a very comprehensive and complete cancer program. My particular interest has been in GYN oncology, as I said from my beginning. But I'm broadly interested, obviously, in all cancers. And our cancer program, which is a comprehensive cancer program, we're certified by the College of Surgeons. We have all kinds of quality measures and quality certifications in the country. And I'm fortunate to work with just an incredible team of physicians, nurses, administrators, pharmacy people, research people, et cetera, here at GBMC that so very much contribute to our efforts in the care of patients, because really what we're about at GBMC is the absolute best care of patients. Our program...
One of the beautiful things about GBMC is that not only do they get Dr. Celano as a doctor, they have a whole team behind them as well.
Right. And that's true. Our program is organized around multidisciplinary teams. So say breast cancer, there is a team of physicians whose primary interest, but not only interest, is in breast cancer. And this centers around not only the medical oncologists, but the surgeons, radiation oncologists, pathologists, laboratory people, radiologists, our social workers, and to all thinking about patients' problems, and whether it's the whole quality program, but also specifically we meet on a weekly basis to discuss patients' care. So that when patients are being cared for at GBMC, it is not just one person, it is a team, although there is a central person, often the medical oncologist, that helps to direct their care and to be part of it. I think that the other thing that's very important to understand about GBMC is we are very much committed to sharing information with patients, so-called shared decision-making, to really communicate what is it that the patient has, what does that mean, what are their options, what can they expect, and also to help them to understand what kind of resources that they need to help them through this problem, whatever it might be.
This conversation is all about communication, and we've received a number of questions specifically for you about various forms of cancer. But I think that we're going to start this conversation in this half hour talking about the one thing that is coloring everything else right now, and that, of course, is COVID, and how COVID has affected how you're treating patients, has affected what is happening at the Cancer Institute, but also, I think primarily because you have a unique perspective, what is happening with the trials that you are working on and the studies that you were doing revolving around COVID and cancer.
Yeah. Yes, it is. This is the COVID pandemic and crisis has affected the entire world and with all aspects of our life. But it is especially critical in patients with chronic illnesses or illnesses where they're immunosuppressed, such as with cancer. It's one thing that is interesting is that we are in the cancer program, and I'll say this across the board in all cancer programs, we are always been very intensely interested in preventing infection. And so a lot of our processes that we have already had in place in terms of preventing infection really just kind of moved almost seamlessly into our care of patients with cancer. So that because preventing infections has been and treating infections has been a huge advance in cancer treatments through the years, and because it can be quite devastating. So in our cancer program, we have been able to continue to care for our patients, although there have been changes. I mean, the thing that hasn't changed is our ability to provide chemotherapy and its various forms to patients. So that has continued to go on, and in a way that's been safe and doable for our patients. But we've also had to adapt how we see patients. For instance, doing the televisits and things like what we're doing right now. Fortunately, I talk to many of my patients just like this through a flat screen, but we still see patients directly. So we have been able to take care of patients. It has affected patients in other ways, clearly. Starting with screening. Many patients, a common question is it okay to have my mammogram? Is it okay to have my colonoscopy, that they're scheduled for? And, we have to sometimes modify that given circumstances and what's happening with the COVID situation. Surgeries has been an issue. All patients having any form of procedure actually at GBMC are screened for the COVID-19. So it is safe for staff, safe for the patients to have these things done. So that's been an important thing. But there have been some slow ups, and it varies with the sort of ebb and flow of the pandemic. Obviously, we're in a bit of a surge right now, actually quite a bit of surge, and so that has affected some of the day-to-day care. But it's, I think we just have to be very, very mindful of how this is there, how we have interacted with our staff and things. So it's, but I will say that we have been able to continue to care for our patients. One thing that we could talk a little more about has been our clinical trials program, where we've been able to continue to not only provide standard of care therapy, but also to allow access to clinical trials that we have ongoing.
Can you give us one example?
Let's give an example of, we at GBMC, we have a very comprehensive clinical trials program We have at any one time somewhere between 55 and 60 trials active on in our cancer program alone. So it includes the entire range of diseases. Giving an example of a novel treatment for a certain type of breast cancer, triple negative breast cancer, where they're receiving not only standard chemotherapy but also immunotherapy, which is another area of new area of therapy for cancer patients. In terms of COVID-19, you mentioned about the clinical trial. We actually have what is really a cancer registry, which we are participating with the American Society of Clinical Oncology and the National Cancer Institute. So any patient that has been affected with cancer and COVID is being followed specifically to see how their clinical outcome is, their clinical course, their problems. Because, as much as we think we know about COVID everyone's still learning, what are the risks, the benefits of therapies, et cetera. Although I will say that the studies that have been done thus far suggest that we can continue to proceed with treatments for patients with cancer, obviously as long as we're providing proper precautions.
I would imagine that the number one question you have for a new cancer patient, someone who has to have chemotherapy, let's say, is probably very concerned about their suppressed immune system. Right. And what if they get COVID?
Well, that's obviously it is a concern. As I mentioned earlier, infection is always a concern in patients receiving immunosuppressive therapy, and having COVID is a danger. I think one of the things, it just emphasizes this thing that sounds so simple, yet seems to be sometimes out of the grasp of some people, has been this idea of using proper masks, of hand washing, social distancing. These are the basics that need to be done, and if they're done properly, will prevent and eliminate things for cancer, for any patient, frankly, but cancer patients in particular. So the more fastidious you can be about these kinds of things, of reporting symptoms, of getting is going to minimize it. I will say that we've seen very little of COVID-19 in our cancer population at GBMC, and I think it's probably a lot of it has to do with patients and how they've really adapted to this. And I think we just have to emphasize this. It's a little bit like, I use this example all the time of putting your seatbelt on. None of us probably get in our cars anymore without putting our seatbelt on, even though we don't maybe need it all the time. Probably need it none of the time, but it's very important that this be done, and that's what I would emphasize to everyone. Obviously, now we have the vaccines, which is a very exciting development, and there have been 2 approved vaccines. One is the Pfizer vaccines, actually, moving out into Maryland here, and soon the Moderna one. And these vaccines obviously will represent a great advantage to patients overall, but obviously patients with cancer. These vaccines, the RNA vaccines that have been developed, are in theory safe for patients. The FDA has ruled this as such, so that there's no reason why a patient with cancer or other immunosuppressed conditions can receive these vaccines. Obviously, we're still learning about how effective they are in this particular population, although, again, the preliminary studies that we have do suggest that they will be protective. But it's certainly a great move in the right direction in terms of preventing the COVID infections.
Celano, we've obviously received a number of questions around COVID and the vaccine. And I'm going to ask you first, when you talk about the vaccine and it being safe, is there any patient in any period within their treatment that you might discourage them from getting the vaccine? Or are you saying at this point, all of my patients should be vaccinated, and we feel confident that no matter what type of cancer they're dealing with, or what type of treatment they're getting, or where they are in what stage, that this would be beneficial for them?
Yeah, I mean, I think generally that the answer to that question is yes. Yes. Um, I think the real kind of wild card in this is certain therapies are more immunosuppressive than others. Certain diseases, certain types of cancers are more immunosuppressive than others. And, what you might expect from the effectiveness of the vaccine may vary. Of course, the vaccines vary anyway with patients. So that's why, there's this emphasis, and I completely agree with it, that even though people are being vaccinated, and this is true for the whole general population, we're still going to need to do all those basic things I listed a little earlier to make sure, to ensure it. So it's kind of a double check on this, and until we're really in the clear, which is not anytime soon, I don't think, we're going to need to continue to do all of this stuff.
Yeah. So I don't think that they're not only, I mean, they're probably, yes, concerned that it would be effective. And I think you're right. I think anyone who's undergoing treatment is probably taking special care to practice good hygiene and so forth. But there's also concern, will there be a side effect? Will there be a side effect that will affect me more deeply and more critically because I am in this situation right now?
And, I think it's always a possibility, although if you look at the sort of other types of vaccinations, the flu vaccination, et cetera, we don't necessarily see that. Although these are a different class of vaccines, these RNA vaccines, there's really essentially nothing like it at this point. So again, we're learning, but and that's why this population is continuing. The patients receiving these are going to continue to be monitored closely. But to date, and there does not seem to be any increased risk. The big ones are clearly fever related to this, which is basically the vaccine essentially jacking up your immune system is really what it is, because many people get fevers after other types of vaccinations, and the other is some pain at the site of the vaccination. But I don't think that I would say that any patient who has cancer, has been treated for cancer, or is being treated for cancer really should not be vaccinated at this point. There's no information that suggests otherwise.
I've had a number of questions about COVID in relationship to particular types of cancer, and some I think are going to be premature for you since you're involved in studies right now. But one asked, and this is probably concerning a little bit the study you're doing, is there one type of cancer worse than another if a patient gets COVID, assuming there's no other illness? And I'm guessing that's too soon for you to answer. Is that right?
Yeah, I mean, it is. I mean, if you were to ask me just as a clinician, the patients I think are at greatest risk from a COVID infection are clearly patients with lung cancers, as an example. Lung cancer is unfortunately still a common cancer in our society, with up to 20% of Americans smoking. Actually, 20% of Marylanders still smoke. So we unfortunately see lung cancer, and as people know, COVID-19 is a lung infection. It's a pneumonia. And so if you already have damaged lungs from cancer and you're getting an infection on top of it, that doesn't sound like a great combination. And so I would have special worry about that patient. But, honestly, in patients who don't have any kind of lung issues, I would still be concerned. But that would be the group that probably is highest risk, because it's such pneumonia overall is a huge problem for patients who have lung cancer because of the pre-existing, damage to the lungs from generally tobacco use, although there are patients, obviously, who get lung cancer who have never smoked, which is also, tragic.
Yeah. If anyone's driven by GBMC in the past couple of days, they've probably seen the sign outside that says no visitors because of COVID, obviously, and because of the uptick in cases. So this question feels very timely today. What support is available? This is coming from someone who asked this question before this interview. What support is available to patients undergoing treatment alone due to the visitor restrictions? As you know, obviously, if you're getting chemotherapy, for example, you're sitting there for a long time, and you used to be able to have someone maybe sit with you or comfort you or just keep you occupied or keep your mind off of it. What can patients do now that may be feeling a little extra isolated?
I completely understand about the anxieties and the concerns of patients going through cancer therapy. And GBMC has been absolutely blessed with a great team. And it starts with our nurses. I mean, we have a terrific group of infusion nurses and nurses who deal with patients receiving cancer therapy, whether it's the outpatient or inpatient side of our system. And these are just warm, personable, and caring, and I will say all certified, oncology certified nurses. They're extremely competent and well trained. And so that is number one. There is just, I mean, I think our nurses are just universally loved. But also, one of the things that we do have at GBMC is a oncology support services. This has been a program that has been in place for over 25 years at this point and continues to grow. And we have social workers that work directly with our cancer patients. So to help, with them in terms of counseling. We have an integrative medicine program that also helps to support patients, whether during treatments or after treatments, or even if they're not getting treatment. We have nurse navigators that also help to assist in our patients. So it's a whole team. And I think that, again, one of the things I think is just a hallmark of our care at GBMC is just this intense interest in the patient and how they're doing. We're not just administering drugs to people. We are truly caring for patients. And I think we're all being affected by this COVID crisis. And so I think we all have especially sensitive to what goes on with our patients and their families, because that's the other side of this is communicating with the families, communicating with, loved ones and significant others and everybody, and making sure people know what's going on and can help.
Yeah, take the mystery out of it as much as possible.
Yes.
Someone else has asked, have more patients been prescribed oral chemotherapy instead of IV therapy because of the pandemic?
Yes and no. The yes part is that there has been a crossover in treatment of patients. When we use the term chemotherapy, we used to mean these IV, highly toxic forms of treatments. That was when I was in beginning of my training, that's basically what it was. Now it's like up to a third of cancers are being treated with oral agents, which are anti-cancer agents. Many of them targeted treatments in terms of target to a specific genetic or mutational change in the patient's cancer. So point one is, what is the right treatment for this particular patient? So, what is their cancer, the type of cancer, the stage of the cancer, what is the other issues and problems, the medical problems that the patient has, what is their desire, what do they want, what is it what's our expectation? So it's a whole complex decision-making process and discussion that needs to go on to determine what is the right thing to do here. Then in terms of, this other new question is, you want to avoid patients having to come too often to the doctor or the hospital. Can you do something orally? And we obviously that's all part of this equation, but, we want to always do the right thing. We don't want to ever compromise treatment if something is better than not, than other, so we want to be sure that we're doing the right thing. So in some circumstances, it does allow us to say, okay, we can go with an oral agent versus an IV thing. Let's go. Although I will say that trend actually preceded COVID. I have no interest in people getting needles stuck in their arms or whatever and getting treatment. If I can do this with something simpler, less toxic, more effective, I'm for it. And I think our whole team is for it. So this is, obviously COVID's maybe put a little more of an explanation point on it, but that's still part of how we're thinking, approaching our patients.
There's so much to talk about when it comes to cancer, and I definitely want to hit on the genetics. And I know you have some thank yous to give, but I just wanted one more COVID question, and I think you can probably answer it quickly. And it's someone who might be concerned that the vaccine would interfere with current cancer, particularly drugs or medications.
There's really no real, even theoretical reason why that should be. I do have some concern about the chemotherapy, for instance, like especially a very immunosuppressive chemotherapy might affect the effectiveness of the vaccine. So I think there might be some timing issues in terms of how we want to time the vaccine. Of course, we don't have it broadly available right now, so it's hard to make any of those kinds of decisions. And obviously, we're still, looking in the medical community is still looking for more information. But I don't see that it would interfere with their cancer treatment. No.
All right. Is GBMC Berman Cancer Center accepting new patients right now?
Yes. Oh.
Always, right?
Oh, always, of course.
Yes. And also genetics. We could do a whole half hour on that, of course.
Of course you could. Yeah.
But could you just touch on, we had a specific question about breast cancer from a former patient of yours. Actually, I'll just ask it and then I'll ask another broad question. She treated her for breast cancer in 2001, so a long time ago. She has had her annual mammogram with no sign of cancer. She has started doing light arm exercises and recently has recognized a pain in both breasts. What do you advise?
I think that this is something that she should be, seen by me or one of the other doctors to see exactly what the cause of this breast discomfort. Just hearing it doesn't sound too serious from that. But that being said, I think I think I need to have a little more information, and also this is something where you really should examine the patient and know what's happening. Obviously, I would want to know that their mammogram was up to date and that this had been checked.
And the genetic question comes from another former patient who had chronic lymphocytic leukemia and wonders if her children should be concerned about developing CLL.
There's no known genetic propensity for CLL or even related illnesses. Like lymphoma would be another example. So there really aren't any genetic concerns, but again, if there was other types of cancers that were more broadly affected in the patient, that might be a reason to have genetic testing. Now, I will say, and this is something that, again, you said this is it could be a long talk, but there's two kinds of genetics we're dealing with in oncology. One is the genetics of heredity, of the things that you can get from your parents that you could pass on to your children, that your sister might have because they're related or whatever. That hereditary genetics, which often dictates a propensity to develop a cancer. The other type of genetics, and this is what's often used for drugs, illnesses like CLL, but almost across the board now, is we also do genetic testing on the patient's tumor. In other words, not so much what happened in their things where they were inherited by, but their actual cancer. And that can have big impact in terms of their prognosis and in terms of therapies, the so-called targeted therapies or immunotherapies that are being used for a variety of cancers. So we have those types of things. So I think those things get often confused a bit, but there's the hereditary genetics and then there's the tumor genetics, which can impact prognosis and treatment and outcomes.
Exciting thing, in your opinion, that's happening in the world of genetics right now that affects you?
In terms of our patients and
what
things.
You're discovering.
Yeah, well, all of this all affects. I mean, the field of genetics is just been completely changed how we view patients with cancer. We used to think of, for instance, lung cancer as basically one disease. Then we thought of it as a couple of different kinds. They look a little different on the microscope. Now lung cancer has become 20 different diseases because there's all these various mutations and changes that can occur that can really dramatically dictate therapy. For instance, there's some genetic changes that can occur in some cancers that can allow us to give patients a pill and will have a very high response rate and treatment with very little side effects. So they're not everybody, but of the patients that this happens to, this is a tremendous change for them. So each patient, and I would say there isn't a cancer we look at now that we're not reviewing genetics in some form or another that's going to impact what we tell patients, what we do for patients, what we expect, all these things that are just important. And the field is just exploding. The same thing is true for the field of immunotherapy, which is the other area that we haven't talked about much today. It has to do with using the patient's immune system to fight cancers. We have, probably 30 different drugs now that are used to somehow enhance the immune system to treat cancer patients. We have these newer therapies like the so-called CAR T therapy, or even newer than that, the bispecific allelic T cell therapies that they were just talked about at the recent ASH meeting, so-called BiTEs therapy. So this whole other area is exploding. And a lot of it, though, has to do with what that specific patient has, what their specific change is, so that we can personalize and direct the care for patients.
Before we say goodbye, let's just take a few minutes to talk about gratitude and how donations really help you and your team do the great work that you do.
Yeah, so GBMC and our cancer program has been the recipient of many benefactors to our program, and even the smallest contribution helps. I do want to especially thank Sandra and Malcolm Berman, who are the namers of our Cancer Institute, who have been tremendous supporters for our program. Greg Collart, the Collart Foundation, has been a great supporter of our research program. Lewis and Phyllis Friedman, supporting our oncology support program. Of course, Herman and Walter Samuelson, Mr. Comey, who recently passed, unfortunately, a supporter also of our program. And then recently, Bob Parsons has supporting our program with a huge gift recently. But I will say that all of these things allow us to do things in our cancer program that we wouldn't otherwise be able to do. I'll separate the research program. We have three full-time research nurses, full-time data managers that allow us to provide these state-of-the-art treatments and clinical trials to patients that we would never be able to support. They function not only to help to facilitate the research, but also, again, to help with patients, to help navigate them and support them through their therapies. Oncology support's another area that, just the support of the program. We unfortunately couldn't have our Legacy Chase event this year, which is devoted to supporting our oncology support services. Again, allowing patients, this is everything from rides to helping with groceries to helping with things, helping support patients. All these things these are not things covered by insurance, and that, to really have the complete care of patients, these donations have been just absolutely critical. And I will say, I mentioned a few names, but I will say anyone who's donated anything to GBMC Cancer Program or Cancer Hospital, frankly, healthcare, I'm just incredibly grateful to, because I know all of this is just so appreciated by our patients, their families, and frankly those of us who take care of patients. It allows us to do a better job at helping with patients and provide this kind of personalized care that we so desperately want to do.
Well, Dr. Paul Celano, we thank you, and we thank all members of your staff, especially during this time, for all the work you're doing at GBMC, and also for joining us today.
Yeah, well, thank you so much. I enjoyed this, and I'm glad to help answer any other questions in the future. Please contact me.